most of you are very familiar with this cartoon, which sort of reflects on the natural history of AKI as we currently understand it, recognizing that there is a significant level of dysfunction after an episode of AKI, and the trajectories may be different. And the controversies which emerged a few years ago in demonstrating whether AKI was contributing to chronic kidney disease has now largely been settled to a large extent by demonstrating that there are significant epidemiological studies showing a relationship. However, the exact mechanisms and how it progresses have not really been well demonstrated. Mostly it is related to associations, but a causal effect has still not been determined overall. We do know that the risk for end-stage renal disease is quite significant, and as you can see in this slide here, there is a marked hazard ratio of increased end-stage renal disease, particularly if you have underlying CKD on which the AKI is superimposed. And what we now currently understand is this thought process that even in chronic kidney disease, progression may be mediated by episodes of acute kidney injury, sort of having them go down the drain faster than they ordinarily would. What that's led to is conceptual models suggesting that you can have repeated episodes of AKI contributing to the decline, but what that ends up then emerging as a set of questions is what contributes to this decline, what are the underlying mechanisms, and can we intervene for this? So we had an AKI meeting on this in Charlottesville last year, and I was fortunate enough to be one of the groups talking about progression. So what I'm going to show you next is the discussion which emerged from that, and this sets into motion some of the opportunities we have for looking at this. So our group was tasked with and came up with 5 broad questions, and I will address each of these in sequence as we go along. But as you can see, these questions relate from some basic questions in terms of how we should approach this whole area and what are the interventions that we can think about. So the first question is, how do we define progression following AKI? And I think this is a question which is very important with respect to terminology, because when we think about what the underlying mechanisms are, it's very important for us to relate this systematically. So notice for a moment that following an insult, any kind of insult to the kidney, there's an admixture of the injury mechanism and the reparative processes, and these start off at the same time. So depending upon both the type of injury, the extent of injury, and the duration of injury, the repair mechanisms, it's the interaction of these two which will determine whether or not there will be healing or scarring going forward. So one of the key questions here is, how do we actually put the terminology to put in place? So it's interesting to think about this a little bit. Repair is anything which starts in terms of it's initiated rapidly and occurs concurrently. An adaptive repair is where there's a resolution of the renal structure, whereas a maladaptive repair is where the original structure is now replaced with something else. So it cannot be repaired completely. And therefore, recovery is actually a consequence of the repair, which is durable. And that, I think, is a very important construct, because as Dr. Chawla showed you earlier, is not only that repair and recovery have started, but how long it is and how quickly it occurs are very important attributes in terms of what the ultimate outcomes would be. And therefore, a progression would be a durable change in the structure or function of the kidney, which is different from what it started out as being. Just to put this in context, if you take a marker level, and if you have a damage marker level, which is like a biomarker, which we've been talking about earlier today, and put this in construct to a functional marker like creatinine, notice that you can have injury ongoing which is never manifest. And that can only be manifest by a subclinical if you measure the biomarker itself, as shown here. You would see that the damage marker threshold is crossed, but not the functional marker threshold. So this would mean the creatinine doesn't change, but you have a biomarker which is changing. In contrast, this is a clinical AKI with adaptive repair, where the injury and repair mechanisms are concurrent. You cross both thresholds, but you return back to close to where those thresholds were, and have complete organizational repair. In contrast with maladaptive repair, your functional marker level ends up being higher than the threshold was. So you're never going to come back to the same level. Your damage marker thresholds continue to be increased, and you have fibrosis overall. And in addition, if you started off with CKD, AKI, and CKD, you were already above a functional marker threshold. You had the injury pattern, so you never really come back to this level itself. And then finally, a construct where you have repeated injury. So here's one episode, there's a second episode, you contribute now to more fibrosis itself. So if we believe these opportunities here, just put in construct overall, you've got both a subclinical AKI, clinically accurate adaptive repair, maladaptive repair, and repetitive injury. These are the clinical patterns that we are likely to see in our patients overall. So the consensus statement we emerged with here was that precise and unambiguous terminology should be used, and that's the one I've just shown you. I think going forward we will recommend that those terminologies might make it easier for us to understand what people were talking about. So the second question is, what's known about the pathophysiological mechanisms following progression in AKI? And now that we have the terminology in place, you could put this in context and say it should be in the context of adaptive versus maladaptive repair processes. And these may be then attributed in terms of a loss of renal reserve, abnormal tubular repair, impaired vascular repair. Each of the component elements of the kidney are subject to changes as we go along. Here's a cartoon that Dr. Chawla and Dr. Kimmel have published in Kidney International, just giving you a broader construct, and I'll take this one step further. This is a very nice article, which is a review article from Dr. Bonventry, just recently published in Nature Review of Nephrology. And you can see here is you have a healthy kidney undergoes an injury pattern, and under these injury patterns, which you have a variety of different events occur, which lead to a reparative process or a scarring. Now, what makes a kidney go down to a repair versus going down to a scarred kidney? Some of the elements that we have started to learn from this have come from mostly preclinical studies of the kind that Dr. Molitor showed you a little earlier today. But a general construct here is here's the endothelial cell, and notice that I'm showing you a pericyte close to the capillary. These pericytes are very close to the capillary loops itself. At the end of an injury, you can have a significant disruption, depending upon the extent and duration of the injury, and release of a variety of mediators which have been identified. And as you go down the repair process, these cells along here, both in terms of macrophage recruitments and everything else, repair the entire thing so you have complete resolution. That's what you expect to happen overall. However, in this construct, the most recent findings have suggested that these pericytes, which are close to the capillary loops, make a major contribution. When there is disruption of the capillary structure and the endothelia here, these pericytes get loose, and they attract, by chemoattractants, a lot of the leukocytes and cause further damage. And vascular rarefaction can contribute to this fibrotic process coming on. So as a consequence of this, you have these three possibilities. You have, as has been already stressed earlier on, this G2M cycle arrest in terms of the cell cycles being going there, in terms of going from AKI to CKD with progressive fibrosis, or you have the endothelium with maladaptive repair and with myofibroblasts contributing to the fibrosis that I showed you earlier. What we do know is then that the sequence of events here are set in motion. All these possibilities are seen clinically. But we don't necessarily track them because our tracking mechanisms are based upon a sequence of looking at creatinine changes over time, and how frequently we measure them determines of how quickly we identify what the course might well be. So there are several models of ischemia and reperfusion injury, of different types of models, which have started exploring these. And I think the knowledge from those models in terms of the elements which are involved will guide us in the future in terms of potential targets that we may be able to achieve there. One construct which is emerging is that you may have a failed differentiation and atrophy after acute injury. And from the basic science, it appears to be that this is where vimentin, one of the molecules, is released, contributes to pro-fibrotic proteins coming into the picture. And these profibric proteins are also, again, determined by the pericytes that I have just told you about earlier. And some of these failed differentiation are related to some of these events, which are from the pathophysiological areas. So in terms of the consensus statement for the second question was, maladaptive repair occurs in the tubular-vascular interstitial compartments in response to AKI, predisposing to interstitial fibrosis itself. So the third question then becomes is essentially what are the relevant biochemical pathways? Because if you could identify these, could you then have a specific target you could go after? And some of the most interesting areas which are emerging here is essentially that there are several potential mechanisms here, but the cell cycle arrest mechanism seems to be quite predominant. And this is, most of the mitosis occurs here, and this G1, G2 phase checkpoint is a key component here. So cells stop dividing, as John already told you earlier today. But what is interesting is, as we all age, senescence is a factor in aging, which seems to have the same attributes as you see in a reparative mechanism after an injury. So the aging kidney, the aged kidney is more vulnerable to this in the same manner as we would expect to happen. So underlying chronic kidney disease itself, and the mechanisms seem to be concurrent. So as you can see here, each of these possible injurious patterns can be contributing downstream into increasing fibrosis and progression overall. So we now have a lot of good information on this, but translating it into human studies is difficult, because we don't, until very recently, have not had the mechanism to say which phase of the disease are we dealing with and how are we going to change that phase of the disease depending upon the attributes itself. So the fourth question here was, can progression to CKD be predicted following AKI and the key risk factors identified? So this raises a broader question, is clinically, what can you do today in the absence of the known biomarkers, and what risk factors are overall? So some of the risk factors which have been clearly identified is obviously the severity of AKI, so the stage of AKI makes a difference. Increasing age, as I've just shown you overall. The mixed multiple causes and multiple hits are a problem, and then certain biomarkers such as proteinuria emerging and staying on is a clear risk factor downstream for progression. But what's more important is also the number of episodes of AKI. And sometimes these episodes of AKI are not well recognized as you go through our clinical practice itself. We've identified another factor in here which is quite simple and fairly modifiable, is anemia. We know now from quite a few studies, and particularly the cardiac surgery literature, that anemia is a risk factor for developing AKI. But we ask the question is anemia a risk factor for recovery? So we analyzed our Picard cohort, which was an observational cohort from 5 centers of patients with fairly severe AKI. And in this setting, we asked for the outcomes in terms of recovery, and looked at was a 20% return, within 20% return to baseline as a method of recovery overall. And then we looked at a univariate and multivariate regression analysis. We divided the patients in terms of the quartiles that they fell into with their hemoglobin levels. And you can see here is that as you went down in the quartile to an anemia level of the lowest quartile, you had a much higher likelihood of non-recovery, and as you went up to the upper third quartiles. And when you put this in a logistic regression and you subdivided these patients into all patients versus those with CKD, there's a significant risk associated with anemia on non-recovery. So I think this is a modifiable risk factor, and ask yourselves is how often do we really pay attention to what the person's hemoglobin level is after an episode of AKI? Because more likely than not, we just simply sign off the patient and send them to the clinic. But that's something that we may be able to address fairly well. What about biomarkers? Certain things like KIM1 and other biomarkers are emerging with respect to predicting whether one will recover or not. And in this context, you've already seen this in terms of the TIMP1 IGF binding protein biomarker profile being a mechanism. But what was published last year from Jay Coyner and from this method is demonstrating that the levels of these biomarkers at baseline also tended to predict their outcomes multiple points later on, suggesting that there may be some prognostic value of some of these biomarkers, but obviously these have to be tested more in general utilization, and further studies are necessary itself. So finally, the last question was, how do we intervene in terms of these elements as we currently know it? And certainly the problem here is that there's a lack of understanding of the disease initiation. Often we are presented with a patient who has developed AKI. We don't really know how they got there. All multiple factors have come into place. We don't know the underlying state of renal function. So the key question then becomes is, if you have AKI on CKD, is it the underlying disease process from CKD which is progressing, or is it the AKI contributing to it? How do we make that distinction, and therefore how do we therapeutically impinge on it? This is some of the things that we don't currently know. The preclinical studies that you've shown so far have already demonstrated some opportunities for us to recognize this in terms of pattern recognition, the use of biomarkers, but we are quite far away from suggesting that we have a therapeutic approach to it at the moment. This is something that we will need to address more in terms of targeting recovery. And just as an example for this is, take these two patients here who start off at a point 1. On the one person, you don't know the baseline where they came on. It would seem to be that this person is progressing further. They both have an AKI episode, but this person's trajectory was already on a decline. So he deteriorates faster than this person who doesn't. So understanding how we track these patients and how we will put them will define intervention time points for us in clinical trials. So there are several research questions which will obviously need to be addressed in this area. I think this is grounds this is very fertile for lots of people to work together on. I think, as Mink already pointed out to us, we have a great opportunity. So far, all our focus has been in terms of saying to identify AKI or diagnose AKI, or how do we get it earlier. I think we need to shift our focus now more in terms of saying is, what do we do with somebody who has had AKI? How do we promote recovery? Because it is the recovery status which determines their ultimate outcomes overall. So these were the 5 members of our group, and I'm indebted to them for letting me show this data to you in their behalf. And again, I'd like to invite you next year for the CRT conference. Thank you very much.